Then the most important is know the anatomy. The orthopedy is nothing but the basic anatomy and glorified carpenter work. So identify the tissues which is being retracted and see how much you can retrieve it back. Because especially those tears involve the supraspinatus and infraspinatus, that accounts for more than 88%, or always most of the time you can easily retract. But those tears which is extending into the infraspinatus can have a delamination type of tears. So you should be very careful about identifying those tears, because these tears basically have a two flap. One have a superior flap and an inferior flap. So unless you take bites through both the flap, you won't get a proper repair, you won't get a proper healing, and you are never going to get a proper strength, especially the external rotations. Almost always I recommend to start with the airoscopy rather than just flushing your fluid into the space, because airoscopy will give you better delineation of the anatomy. As you see here, you can see the anterior labrum, the cuff, the long head of the biceps, everything will be pristine. So you can get a better idea about what is the native anatomy. Because once your fluid comes in, this will start to the flavid tissues will come in front of you. So that will make it difficult to identify or discriminate the anatomy, especially in some chronic tears. Because without any fluid, the bursal tissue usually won't come into your field. Look at this picture. You can see very clean, pristine images if you try to do the scopy with the air. And once the tendon is found to have a retracted or a chronic tear, you have to do a release. Basically, you have to do a 3-point release. One is a coracoid, base of the coracoid, because the anterior part of the tendon will go and adhere to the anterior part of the coracoid, especially the rotator interval area. So you need to release the tendon both from outside and also through the joint itself to get a proper pliability for your tissue. And then second area is the capsule, area between the superior labrum and under surface of the cuff. But once you go beyond more than 1.5 centimeters, you should be careful about suprascapular nerve. And the third is release from the spine of the scapula. Again, you have to be, because the spine is an important anatomical landmark for you. Because the spine of the scapula, whatever anterior to the spine of the scapula is supraspinatus, and whatever posterior to the spine will be infraspinatus. So you can go along the infraspinatus. So especially in those cases, you require something known as interval slide, or those cases better clean the spine of the scapula. So this is some of the images. You can see the first scopy image. You can see the tendon is not at all coming even up to the joint. But once you do the proper release, you can see the tendon is easily coming up. And also in the lower picture itself, you can see there is an adhesions, especially the posterior parts. So once you start to release the adhesions, you can see even with your radiofrequency ablator, you can just lift off your cuff so easily. That shows your cuff is freely mobile. That is what is the most important key steps, especially when you are planning to repair a chronic tear. Because if the cuff is more tight, more adherent, absolutely 100% your cuff is going to fail, because there is high tear of re-tear, especially when the cuff is more fibrotic. So you need to release it and make it pliable.